Good evening, Dr. Gauri Shankar sir. Good evening.
Good evening, Pa.
Singaros are there. Very good.
Aarti has also joined, madam.
Okay,
Yeah,
sir.
Dr. Subramaniam has joined. Oh, that actually Dr. LS sir.
Dr. LS sir, sir.
Yeah. Sir, good evening, Dr. LS sir.
Good evening, good evening.
Yeah.
Sir, good evening, sir.
Good evening.
Good evening, sir. Good evening.
Good evening, good evening.
Good evening, sir.
Yeah. Dr. Aarti. Yeah. Good evening.
Dr. Aarti, can we check whether you can share your presentation, no?
Yes, ma'am.
I have to, should I have to make her co-host, ma'am? Can you share, ma'am?
Ma'am, I have sent the request, ma'am.
Okay, then wait, ma. Wait.
Host மாத்தீங்களா
Sir, good morning, sir. Yes, sir. Host வந்து திரு sir தான் sir இப்போ. Sir, எப்படி இருக்கீங்க? Good evening.
Good evening, Dr. Murugesan.
Good evening,
sir.
Murugesan.
Good evening, sir. Dr. Murugesh, Dr. Rajkumar, Dr. Professor SBS sir. Good evening, good evening.
Singaravelle also has joined, but he is muted.
Oh, I think sir is busy now, sir. He told that he'll join.
Okay.
Good evening, sir.
Sir, I will remind once NK sir and come, sir.
Okay, sir.
Good evening, sir.
Good evening, Dr. Gauri. How are you?
Fine, thank you, sir.
Sir, good evening, sir.
Good evening, Professor SBS sir.
Riga, Manohar.
Dr.
Good evening, sir.
SPS, good evening. Listen to your lecture in the afternoon.
Visu, how are you?
Fine, sir. Fine, sir. How are you?
Good evening, Soma.
Sir, good evening, sir. Welcome to Gauri,
Yeah.
sir. Good evening.
Oh,
Sir, good
Manohar,
evening, sir.
good evening, Somo.
Good evening, sir. Good evening, Manohar, sir. Good evening. SPS, sir. Good evening, sir. Welcome.
Yes, good evening, Soms.
Good evening, sir.
Somo, Dr. LS sir join பண்ணிருக்கா பாருங்க.
Oh, okay. Sir, இருக்காரா, sir?
Karpa, mute la karpa.
Okay. Sir, Sir, LS, sir. Good evening. Murugesh.
Sir, good evening, sir.
Good evening.
Murugesh, good evening.
MSP Vas, good evening.
Good evening, sir. Good evening, Shams. Good evening, good evening.
Prasanna, welcome.
Sir, good evening, sir.
Irukkaru. Subramaniam, sir. Subramaniam Lingareddy, sir. Irukkaru. LS, sir.
Sir,
Welcome
LS,
to
sir.
this.
That
forum.
is LS, sir. NK sir is joining, sir.
Okay.
NK Subramania sir just joined.
Sir, should I call
Good
you
evening.
Anthony, sir?
Good evening to all.
Janani, madam. Welcome, madam.
Yeah, good evening to all.
Good evening, madam.
Dr. Jenny,
evening.
good evening.
Good evening, sir.
Good.
Hi, Gauri Shankar, good evening.
Good evening, Janani.
Kritika, Narmada மாத்திரம் ஒரு கால் கொடுத்துருங்களா?
Yes,
ராஜ்குமார்
sir. I called her.
welcome.
Madam had joined and 1 minute, sir.
நான் இங்க தான் இருக்கேன்.
Yeah. Good evening.
SP sir has also joined, sir.
Can we start the program?
Dr.
லைவ் கொடுத்துடலாம். லைவ்
Live வந்து கொடுத்துட்டாரு.
கிருத்திகா லைவ் சொல்லிடுறீங்களா? திருமுருகன்.
Yes, sir. Yes, sir. Thiru sir is now host, sir. He is here only. Thiru sir.
Dr. Anthony.
சார் அந்த நெக்ஸ்ட் செஷன் தானே சார்? ஃபர்ஸ்ட் கௌரி சங்கர் சாருடைய அந்த பேர்ல்ஸ்.
Ma'am, you are the host now, ma'am. Can you make me the host, ma'am?
செக் பண்ணிடலாமா? அவங்க அந்த பிரசன்டருடைய
Yes, sir.
PG sync co-host back there.
Sir?
PG sync co-host. Okay.
Yes, sir.
Good evening, Rajkumar. Sorry.
Muted. Rajkumar is muted.
Sorry. Good evening. Good evening.
Sir, Subramania
sir.
sir has joined, sir.
Good evening,
Okay,
Subramania
good.
sir.
Sir,
Good evening.
sir,
Narmada, how are you? Gauri?
Yes, sir. Good evening, sir.
good evening, Dr. Subramania sir.
Sir, good evening,
Good
sir.
evening, good evening. Good evening.
Sir, good evening, sir. Good
Sir,
evening,
good
sir.
evening, sir.
Balasubramaniam sir, namaste.
Good evening, Subbo. Long time no see.
Good evening, Professor Subramanian sir. Good evening.
Shall we start, madam?
Yeah, we can start. Somasundram, can we start?
இது அவங்க ஸ்லைடு மாத்திரம் ஒரு தடவை செக் பண்ணிக்கலாமா?
Aarti, can you please check whether you can share the slides, ma? You are the co-host now.
Yes, ma'am.
Okay, ma. Go to the slideshow. See whether we can move the slides, ma.
Subramania sir, welcome.
Perfect.
How are
Okay, ma,
you?
you can stop sharing.
Yes.
Thank you.
Fine.
Stop sharing, ma.
Nice
Yes,
to
ma'am.
see you.
Good.
Sir.
Long time not seen.
Okay, can we start, Kritika?
Yes,
Yeah.
ma'am. Yes, ma'am.
Yes.
A very good evening to all of you who have joined on this platform for yet another interesting session on postgraduate teaching, as well as we are going to learn from the teacher of teachers, Dr. Gauri Shankar sir, on a very interesting scenario. For starting this program, I request Dr. Rajkumar, our treasurer, to kindly do the pediatrician's prayer and start the program.
Thank you, Narmada. Pediatrician prayer. Grant us the quality of holistic healing. May we humbly realize how privileged we are in being bestowed with the ability to alleviate suffering. May we be emissaries of health, learning, charity, peace, love to all children and their families, irrespective of status and creed. Give us the wisdom, understanding to change the things we can within retain the good and accept within reason the things we cannot change. Grant us your blessings, grace, and mercy in all situations at all times amidst all people. Thank you. Over to you, Narmada.
Thank you so much, Rajkumar. I request Dr. Somasundram sir to welcome the delegates, President IAP Tamil Nadu State Chapter.
Yeah. So thank you, Dr. Narmada. Respected TNSC office bearers, Secretary Dr. Narmada, Vice President Dr. MSV, Treasurer Dr. Rajkumar, our academic coordinator Dr. TN Manogar sir, the convener of this PG teaching program, Dr. SPS sir, and the coordinators, Dr. Prasanna and Dr. Kritika, and the faculties for today, the experts in pulmonology, Dr. Gauri Shankar sir, Dr. N.K. Subramania, Dr. Murugesh Lakshmanan, and Dr. Anthony Terence, and the various dignitaries who have joined on this platform, respected Dr. L.S. sir, Kennedy madam, and few more dignitaries who have joined on this platform. So welcome you all for this third session of PG teaching by IAP Tamil Nadu State Chapter. As you all know, this year we have a bit modified the session with which should be useful for both postgraduates and a topic which will be useful for the postgraduates, which will not be discussed in detail during the presentation. That will be for the first 15 minutes, and in that time, a few PGs will be taking time to log in, and so that will be useful for the PGs to hear the postgraduate session from the start itself. So today's session is completely dedicated to respiratory system, with TB diagnostic to start with Dr. Gauri Shankar sir, and a PG case presentation on respiratory system by the postgraduates from Coimbatore. So happy learning to all of you for this third session of virtual Gurukulam by IAP Tamil Nadu State Chapter. Over to Dr. Narmada.
Thank you so much, Dr. Somasundram. Yes, in fact, we wanted to have one topic which will be discussed in detail by the expert in that, so that even practitioners who are listening to this will be benefited. And we are having such an elite panel today. I request Dr. Manohar sir, our academic coordinator, to kindly introduce and start the program.
Thank you, Dr. Narmada. Good evening, friends. My appreciations And thanks to Dr. Kritika, the convener, Dr. S. Balasubramaniam, the advisor, and Dr. Prasanna Raju, the coordinator of this virtual Gurukulam program. For Pediatric Pearls presentation on updates in TB diagnosis, we have with us Dr. Gauri Shankar, a shrewd clinician and a good teacher. For respiratory system clinical case presentations, we have discussions. We have with us Dr. Professor N.K. Subramania from Karnataka. Thank you, Dr. Subramania, for your valuable time. And also, we have with us Professor Dr. Murugesh Lakshmanan, Professor of Pediatrics at Pudukkottai Government Medical College, Dr. B. Anthony Terence from Kovai. All of them, Dr. Gauri Shankar, Dr. N.K. Subramania, Dr. Murugesh Lakshmanan, and Dr. B. Anthony Terence, all of them are having vast experience in pulmonology, and they are excellent teachers. They've spoken in many of the platforms at national level. And our best wishes to Dr. Aarti, the final year student from GKNM Hospital, for her presentation and also for a bright future in her career. Over to you, Dr. Narmada.
Thank you so much, sir.
Thank you, sir.
And we are really having a very allied panel, and I'm very sure it's going to be a very exciting session today. I'll hand over to the coordinators of the program, Dr. Prasanna and Dr. Kritika, who are very keenly interested and who take meticulous effort to see that they get the best of the people and the students across the state. And over to you, Kritika and Prasanna, for further proceedings.
Thank you, madam. It is indeed a great pleasure to see two of my most ardent and fan of Dr. SBS sir and Dr. Gauri Shankar sir. I had the privilege and happiness to take up pulmonology because of two people, one Dr. SBS sir and another is Dr. Gauri Shankar sir. And on top of it, I used to see a lot of videos of N.K. Subramania sir. I told him that I follow him like Eklavya. So there are the Trimurtis of pulmonology today. There is no bigger stadium than this to have these three big frontline batsmen. So I wish people, postgraduates who see now and also after this program, who follow this program from YouTube, to pick up a lot of pulmonology points, core pulmonology points. A brief introduction about N.K. Subramania sir. He is a professor and a medical superintendent at NTR University. He has been a vice president IAP South Zone, and he has been a chairman IAP NRC 2021-22. He has many orations and he has been editor for many journals. And a brief introduction about NC Gauri Shankar sir. He is professor and head of Pediatric, Secretary IAP NRC 2017-18, and he has been editor of IJPP and many journals, and he has numerous publications under his belt. And we also have our own batsman, Dr. Murugesh sir. He is a professor and HOD of Pediatrics from Pudukkottai. I welcome you also, sir. He is a secretary, Pediatric Infectious Disease, Tamil Nadu chapter. So with this brief introduction, I hand over to Dr. Kritika to proceed with the proceedings.
Thank you, sir. Respected IAP office bearers, respected teachers and dignitaries, good evening. So we are into the third clinical program of Virtual Gurukulam 2.0. Welcome Dr. NC Gauri Shankar sir for presenting the first session. Sir, the stage is yours, sir.
Thank you, Dr.
On
Kritika.
what is new in TB diagnostics. It's a pleasure to listen to you, sir.
Thank you, Dr. Kritika.
Thank you, sir.
Hope my slides are visible.
Yes, sir. Your slides are visible. You are audible, sir.
Visible.
Thank you very much. TB diagnostics, what is new? Thanks to all my teachers and the teacher who is present in this session, Dr. L. Subramaniam sir. Pranams to you, sir. TB diagnostics, what is new? I don't have anything new. This is the first point which I have to say. But we'll just try to refresh what we know in TB diagnostics. We need to know what is new to diagnose TB infection. Traditionally, we have direct methods which will detect bacilli or DNA by either smear, nucleic acid amplification test, or culture. Indirect methods, they find out the reaction of the body to TB bacilli, usually our tuberculin skin test Manto previously, and your interferon gamma release assay. But we have most important investigation, which does not fit into direct and indirect method, that is imaging. Most of the time we have difficulty in obtaining body fluid samples. So we resort to imaging very frequently, almost all 100%. We'll look at X-ray. You know, TB specific CAD, computer assisted detection software application using AI can improve the X-ray sensitivity and specificity, but still it is not recommended for use in TB diagnosis in children less than 5 years. Why? Because the X-ray from this age group, less than 15 years, were not used in the development, and the TB often causes many different X-ray findings in children. Next comes CT. It is useful when there is inconclusive radiographic finding. When you have a symptomatic patient with a normal X-ray, if the diagnosis is not certain, or if there is to find out if there are any complication in endobronchial TB, also follow up complicated cases. Ultrasound, the new tool, this can allow visualization of the changes in the lung, consolidation, cavitation, and miliary nodule. But look at the red letters. Only if the changes are directly in contact with pleura, with no aerated lung in between. Though it can detect with great difficulty a hilar adenopathy. MRI allows very early diagnosis as far as osteoarticular or CNS TB is concerned. It is more sensitive too. Coming to positron emission tomography, not much used, but it can detect active disease in most organs except in TB and CNS. But remember, it gives a lot of exposure. There is more radiation exposure compared to CT, but the advantages are there. It is able to differentiate TB disease from TB infection and residual disease. It's able to give us an assessment of the extension of the TB disease. It is able to identify sites which are suitable, which will be suitable for biopsy, also to monitor response to treatment. Now we come to the liquid automated culture. This is WHO endorse MGIT, microbacterial growth indicator tube. This is the most sensitive confirmatory method available, especially in those with extrapulmonary TB. Culture should be performed whenever feasible on all diagnostic samples. Then we have the detection of nucleic acid by nucleic acid amplification test. You have moderate complexity automated NATs. One will be your gene expert mission. This is a detect MTB as well as rifampicin resistance in a single cartilage. Please note that it will not do well in those who are smear negative and in those who are having HIV. An important sample, what has been recommended by WHO, is to examine this tool as an alternative for your lung fluid, like your sputum or lung fluid. What is the basis? Pulmonary mucociliary escalator, it drains the lung debris into the GIT. Both ways of GI sampling, either gastric lavage or stool test or rectal swab, may allow the TB bacilli detection. Another moderate complexity automated NAT is your TNAT by MolBio. It is more complex text from the user perspective. That means the lab personnel will find it unless they're trained properly. It has got limited data on the diagnostic accuracy in specific groups, in those with HIV and in those with extrapulmonary TB. Why I say extrapulmonary? More common in pediatrics. Another moderate complexity automated NAT is your LAMP, loop mediated isothermal amplification. It's a manual assay. It is ready to or rapid and easy to perform. But the disadvantages are it does not detect the resistant to drugs. So this is not used much because we want to find out whether there is rifampicin resistant upfront before we start our treatment. You have low complexity automated NAT. That is your MDR or XDR expert. It detects MTB and resistance not only to rifampicin but also INH, fluoroquinolone, amikacin, kanamycin, capreomycin, and ethionamide. Though the limit of detection is higher than you compare for GeneXpert or GeneXpert Ultra. But please don't ask for this test when you have a reading of MTB complex trace detected, where you will have the reading of rifampicin resistance indeterminate. Don't do that. When the bacillary load is low, this is what you are going to get, MTB complex trace detected with rifampicin resistance indeterminate. You have another NAT, line probe assay, which can detect MTB and resistance to rifampicin, INH, pyrazinamide, fluoroquinolone, and second line injectable. It can be performed only on sputum smear positive specimen or if the culture shows positivity. It cannot determine resistance to individual drugs in the fluoroquinolone class. And it leaves out some of the mutation. So maybe line probe assay probably for rifampicin and INH and second line injectables, but if you don't have any other means. Now coming to TB infection. Why so much is being talked about TB infection? What is TB infection? It is the asymptomatic non-transmissible clinical state when the immune system reacts on exposure to MTB antigen. Here there is no illness, but the main drawback is the tuberculosis infection can progress to active TB, especially when the immune system is not functioning properly. Not always, even at times of rapid growth, your immune system may not work properly. Identify the TB infection either by IGRA or TST and treatment of TBI. They are very important strategy in the elimination against TB. That is why now everyone is talking about TB infection, even though previously it was called as latent TB infection. Now it is only TBI, TB infection. You can detect it by using interferon gamma release assay, which is a blood test. Here it detects the interferon gamma released by sensitized T cells by specific MTB antigens. Early secretory antigen test 6 and cell-filtrate protein 10. It requires the infected person to have an adequate immune response. So it may not perform well when the resistance or when the immune system is not working less than 2 years. Probably people who are immunocompromised, it may not give you a good result. It has got a higher specificity because the antigens ESAT6 and CFP is not present in the BCG strain of Mycobacterium bovis and in non-tuberculous mycobacteria, except Mycobacterium cancersae, marinum, zulgae, and flavescens. IGRA test, it is as the result comes out in a big page. You will have a positive control. Why you have a positive control? It assesses the cellular immunity of the particular individual. Even though it does not distinguish infection from disease, it cannot predict the TB progression. The results can be positive, negative, or indeterminate. Why indeterminate? Especially in children who are aged less than 2 years, they may not have an adequate functioning immune system. The diagnostic yield from different IGRAs are similar. Previously, we had the Manto. It has got a higher false positivity rate in BCG vaccinated individuals and those who have NTM. But You have the new test, Sci-TB skin test, overcomes the limitation of your Manto and IGRA. It contains two specific antigens, early secretory antigen target 6 and cell-filtrate protein 10, which is secreted by the MTB complex. It is administered and read similar to your Manto. You need to read the Sci-TB test at 48 to 72 hours after the intradermal injection. An induration of more than 5 millimeters is positive. So, in other words, your Sci-TB, you can call this as a skin IGRA test. Similar to how you do a Manto with a 0.1 ml, you need to store the fluid in the refrigeration 2 to 8 degrees centigrade. You need to keep it, allow it to come to the room temperature once before you start using. Up to 28 days, you can use it. You need to have a wheel of about 6 millimeters or more. If there is going to be less than 6 millimeters wheel, you have to repeat the test 2 inches away from the original site or on the opposite arm. Always you cannot read it before 48 hours or after 72 hours, only 48 to 72 hours. In between this time only you have to read it. You need to palpate for the induration. If the margins of induration are irregular, mark and measure the longest diameter in the transverse axis using a plastic scale. Ballpoint method, again this has been endorsed by NTEP2. You draw a ballpoint pen line on the transverse axis of the forearm, start 2 centimeters away from the visible skin test reaction, move slowly towards its center, exerting moderate pressure against the skin. The point where you have the resistance to the pen displacement occurs. This is the point of the outer limit of induration. Do it on both sides and then measure the reading in millimeters using a plastic scale. A positive test indicates infection with MTB regardless of CD4 cell count or underlying immunocompromised state of the person. Negative test. You can have a negative test if the patient has acquired an infection very recently. He has not had enough time for the body to react to the skin test. Can you repeat a Sci-TB test? Usually it is not recommended except in special situations, especially if you are screening individuals such as healthcare professionals or when you have contact to active TB case, you can repeat the Sci-TB. What is the current recommendation? You can do the Sci-TB test in those who are only 18 years and above. This is as far as the NTEP, National TB Elimination Program is concerned. But we are doing studies. So the regulatory approval for Sci-TB has come from ICMR and the Central Drug Standard Control Organization for those above 1 year. So many studies are being now going on, like using Sci-TB for those above 1 year of age. Is there any likelihood of false positivity? Very low likelihood for false positivity. If it is a positive test, always rule out TB disease. And if the TB disease is ruled out, then you can start your TB preventive therapy. Is there any adverse effect if you have a vaccination? No. Vaccination with live viruses or BCG does not interfere with your Sci-TB skin test result. So, coming to the last slide, for TB elimination, you need to diagnose TB infection among the household context of TB patient. This is going to be the most effective strategy. Using Sci-TB tests in high-risk population to detect and treat TBI is the most cost-effective intervention. Why do you have to treat TBI? Only when you treat TB infection, you can achieve TB elimination goal. Thank you. These are my references, and thank you.
Thank you so much, sir, for the clear, crisp, and the same time comprehensive lecture. So may I request Professor Dr. L.S. sir to share his experiences?
Let me congratulate Dr. Gauri Shankar
for crisp diagnosis of tuberculosis. Today I learned the new test, CY-TB test, which is new to me. The other test, of course, I repeatedly used to hear. Once again, I congratulate Dr. Gauri.
Thank you so much, sir. SBS, sir.
No, nothing except that we are used to the disciplined way Gauri Shankar delivers his messages. Excellent, Gauri. And I mean, he brought in. I'm happy that I was just looking forward to his opinion on CY-TB, and he has very clearly pointed out it is no more treating TB disease. We have started now treating TB infection. So the goal is to eradicate, and unless we start treating so-called what we used to call as latent TB, we will never eradicate TB. And CY-TB, Gauri knows, ICMR, I don't know for what reasons they are delaying the introduction. There are some bottlenecks there. Similarly, even latent TB guidelines, a shorter course of TB in the form of 4 months therapy, and using remote X-ray diagnosis in adults and children. These are new things which are being tried by the National Institute of Research in Tuberculosis. I am sure, at least if not by 2030, we'll be able to eradicate tuberculosis by 2035 at least. Thank you. Excellent, Gauri, as expected.
Let your wisdom words come true, sir. Thank you so much for the excellent lecture, Gauri Shankar, sir, again. So having completed and having learned new pediatric pearls from Dr. Gauri Shankar, sir, we are into the second part of the virtual Gurukulam 2.0. So we have with us Dr. Aarti, who will be presenting a case on respiratory system, ably mentored by Dr. Anthony Terence from the GKNM Institute, Coimbatore. And they are going to be assessed and fine-tuned by 2 professors, Subramania NK sir from Kuppam Medical College and Murugesh Lakshmanan sir from Pudukkottai Medical College. We are all looking forward to the presentation and the interaction. Aarti, can you please share your slides, ma'am?
Yes, ma'am.
Subramania sir, Murugesh sir, shall we start the session? Okay, sir. Aarti, please proceed.
Yes, ma'am. Respected professors, respected sir, ma'am, I'm Dr. Aarti N, final year pediatric PG from GKNM Hospital, Coimbatore. First, I would like to thank everyone for providing me the opportunity to present in this forum.
Yes. Yes, ma, your slides are moving. Yeah.
Yes. So today I'm going to present clinical presentation of a child, Master X, who's 5 years old, who's a preschooler, and 4th born to 3rd degree consanguineous marriage, who's coming from Palladam, and brought by parents. Reliability was good. Presented with complaints of wet cough since 3 months of age and failure to gain weight since 3 months of age. Since the complaints have started from the early infancy, I would like to start from the antenatal history. So first trimester, it was a spontaneous conception. Folic acid supplements were taken. No fever or radiation exposure. First trimester scan was said to be normal. Second trimester, quickening was felt at 5 months of gestation. Anomaly scan was said to be normal. Iron and folic acid supplements were taken. There was no history of gestational diabetes mellitus, PH, or hypothyroidism. Third trimester, growth scan was said to be normal. Iron and calcium supplements were continued. There was no history of fever. Natal history, he was born as a full term via LSES, indication being previous LSES, with a birth weight of 2.8 kg. He immediately cried at birth. There was no resuscitation required at birth. Postnatal history, he was immediately breastfed. There was no history of neonatal hyperbilirubinemia or NICU stay. He passed urine on day 1 of life and he passed meconium on day 2 of life. He was started on formula feeds due to lactational failure and presented with complaints of wet cough since 3 months of age. It was insidious onset, persistent in nature. It was more during early morning time, no positional variation. It was not associated with breathlessness and not feed related. Episodic worsening of cough were treated with antibiotics. And there was a history of passing oily and bulky stool since early infancy, 4 to 5 episodes per day. It was pale, foul-smelling, and greasy. There was no blood in stools. And he had a history of poor weight gain between 3 to 6 months of age despite adequate feeding. And no history suggestive of difficulty in feeding. And at 4 months of age, during April month, he required hospitalization for vomiting, tiredness, and seizures. On evaluation, he was found to have salt loss and advised for genetic testing. There was no skin infections, no oral thrush, no persistent nasal discharge or ear discharge, no history of feeding difficulty and hurried breathing or blue episodes. At 5 months of age, he was evaluated at hospital and he was started on oral medicine, which were given with food to improve the digestion. And also he prescribed with vitamin supplements and he was advised chest physiotherapy. So during follow-up, he showed improvement in cough, weight gain after starting the treatment. He had a history of mouth breathing and snoring for 1 year since 3 years of age and found to have during evaluation, he was noted to have nasal polyp and which was treated symptomatically in the initial period. At 4 years of age, he underwent surgical removal of the nasal polyp and adenoids. So currently came for routine follow.
Respected Subramania sir and Murugesh sir, you can stop Aarti anytime and you can ask questions.
Yeah, let her complete. Let
Okay,
her complete history and then we'll come back.
Okay, sir. Okay, sir.
Coming to the developmental history, development was appropriate for age. He was immunized up to age as per national immunization schedule. Additional vaccines were given, which was Prevnar, PCV13, and flu. Nutrition history. So 24 hours recall method was used. We have calculated the calorie at present, and he was breastfed till 6 months, and he required formula feeds for in view of lactational failure. From 6 months of age, he was started on complementary feeds. So he was on high calorie, high protein, high fat diet with extra added ghee and oil with salt. So the daily calorie intake expected is 1,400 kilocalories per day and observed is 1,336 calories and deficit is 64 kilocalories. Proteins expected 24 grams, observed 20. He was taking 26 grams and there was no deficit observed. Family history. So this is a 3-generation family pedigree chart. So the child's father had twin brother death. He couldn't remember the class. The child is a 4th born to 3rd degree consanguineous parents. So he also had 2 male sibling death. The first sibling was died at 3 months of age. So due to salt loss and dehydration, he was not evaluated at the time. And second sibling, he was died at 5 months of age due to post-vaccination reaction allergy. And he also had poor weight gain since early infancy. And he currently has a elder sister who is doing well. Coming to socioeconomic history, so father's education, he studied up to high school. He's a construction worker, semi-skilled labor. So mother is a degree holder, she has studied MBA and she is currently a homemaker. So monthly income is 30,000 per month and per capita income is 7,500. So they live in Paka house with 2 rooms with 2 windows each. They have separate sanitary facilities. They have drinking water from the municipality. They use gas stove for cooking. According to the modified Kupasamy scale, they are classified into class 3 lower middle class, and there was no exposure to smoking or pet animals and no contact with the TB patient. Treatment, he was on airway clearance therapy, pancreatic enzyme supplements, high calorie, high protein, high fat diet with added salt, with vitamin supplementation, and he required antibiotics during chest flare-up. Summary, a 5-year-old boy who's a fourth born to third degree consanguineous parents presented with persistent wet cough, poor weight gain, oily stools from 3 months of age. He also had recurrent salt loss and dehydration, which required hospitalization for that. And he underwent nasal polypectomy and adenylectomy. He had a positive family history of sibling death. So from history, the history suggestive of chronic suppurative lung disease. The differentials can be cystic fibrosis and non-cystic fibrosis related. That is post-infectious, localized foreign body, primary or secondary immunodeficiency, then primary ciliary dyskinesias, aspiration, and congenital airway malformations.
Why do you think of foreign body? Actually, symptoms started, I think, early infancy, 3 months. So highly unlikely for a foreign body to be present at that point of time.
Less likely, sir.
Okay.
Can I come in? Murugesh sir?
Yes,
Can
sir.
I ask a couple of
Sir,
questions?
please, sir.
Yes, sir.
Yeah. Arti, I will take the presentation analysis in 2 parts. One, that you are a young DNB student aspirant to do very well in exams, not just pass, but pass in high colors, versus the clinical diagnosis. When you want to present extremely well, you please listen to the following things. If required, you can note down with a piece of paper, and maybe all the postgraduates who are listening. This is exclusively tips for postgraduates, what you should do and what you should not do in exams. The first point is, go to the first slide. My criticism about Arti, let me start with negatives. You are monotonous, monologue in your presentation. You have to have some variations better. My point is now, let me show you what is monotonous presentation. Master X with 5-year-old, wet cough since 3 months, failure to gain in weight. There is no expression of anything empathy about the mother or the pain of the family, or what you want to highlight, what you don't want to highlight. This should be part of your art of presentation, because what happens is most of the examiners would have traveled overnight. They'll be drowsing, and suddenly when you tell something, they'll wake up. What if there is an examiner like Dr. Somshekar R who asked, is it a primary lactation failure or not? See, if he comes as examiner, he will leave cystic fibrosis of the diagnosis. He will go on about lactation. You are getting my point, Arti. So the smartness lies in you not to take him on the questions of lactation. Dr. Somshekar, accept my apologies. My point was that she should not face the bouncers from good bowlers like examiners. You should be smart batsman. You should dictate the examiner to ask questions in the way you want for the primary disease in question. That can happen if and only if you present. For example, wet cough since just 3 months of age, that 3 months should come from you. And failure to gain weight ever since then. Ever since the wet cough started, the failure to gain weight also started. You mean to say, if you look at the way and expressions with which I presented now, I added a bit of variations in the voice, and that's what makes you a good presenter in most of the conferences, webinars, CMEs, as well as in future. I want to see you on biggest platform of IAP or any other congress to see you presenting with a bold chest and telling you this presentation. Can you go to the next slide? I think what you should tell here is, Don't say folic acid was given, iron, calcium. We are fed up of listening to them unless this iron, calcium could make a difference. So although I probed more, there was nothing significant in antenatal history, either in the first trimester, second trimester, or third trimester. Maybe related to folic acid supplements, iron, calcium supplements, or anomaly scan taken. You know, you look at the flow in which I am presenting to you. Dr. Arati, did you get the point? You should know how to play up or play down the presentations when required. That makes you a smart presenter, and examiners are going to not ask you, tell me the highlights or give me important points. They would have already got the important points from the way that you are presented, especially if you are rushing through the exams and if you have less time. This is first part. Now I will not go into the semantics of presentation. This is because any postgraduate is presenting should be benefited from the faculties as well as from the professors. Therefore, I gave you these couple of tips. You try this in your DNB exam, and I'm expecting one half kilo of Mysore pak from Coimbatore to be delivered to my house. Okay, even if I gain half kilo more, it's okay. That's the first part. Second, I'll make you happier. Now, you come back to the first line, wet cough at 3 months. How did you diagnose wet cough from the mother? What made you to think wet cough? The baby can't bring out the sputum at 3 months. All right, I accept the point of cough. As a pulmonologist, not as a pediatrician, I'm very keen to know a postgraduate presenting a wet cough.
There was some moistness in cough which was noted by the mother.
No, but I beg to disagree. You must be final year presenter, and you would have asked many mothers, even for that nose gorgora. Also, mother says the lung is full of fluid, half a tank of pus is there in the chest, sir. Put the lung in washing machine, clean it up and give it back to me. This is exactly mother's version. Do you agree, Arati?
Yes, sir.
Everything is wet for them. Even I see mothers who will put the hands in the nose, chest, or in the throat, swipe it across and remove some phlegm. I'm sorry, this is practiced in different parts of the country. I have traveled across the country, and many places we have asked many of the students, consultants who will give the same explanation, phlegm. Even if there is a vomiting following bouts of dry cough, whatever contents of the stomach comes, they will never tell it is gastric in origin. They will tell it is lung in origin. Are you getting my point? Different words are used in different languages. In Tamil, I don't know what they call kapham, probably. So they use different terminologies for the same. So wet cough, when you use the word, you must tell that whether it is in bouts. What if it is pertussis? For example, an infective cough and you made a diagnosis of cystic fibrosis. It cannot. Please understand, I'm not telling pertussis will produce wet cough, but my point is, when she is telling wet cough, is she telling because it is wet, or is it because mother wants to hype it as wet cough and draw your attention? I think as a postgraduate, you should have this smartness. Most of you, if you put your hand on the chest of the child, and as and when it is coughing, you can see that gurgling on the chest of the baby, and you can even make out whether it is conducted sound or a wet cough in origin. Many a times these sputums are palpable. I'm sorry for these words. How many of you have ever, tried to do this experience? Kritika, I would request you to give me a feedback on this. From tomorrow in the clinics, start putting your palm on the chest of many babies. You can really get that sputum out into your palm. I don't know how, but it is possible. I'm not able to explain beyond this, and it is possible. Even better than stethoscope many a times. Stethoscopes will confuse you with, magnification of the sound, but with the hands you can get in. Arti, you would also try and give me a feedback. This is too subjective, and I don't have evidence. But wet cough is defined as any cough that will definitely produce a demonstrable sputum. Okay, I will stop at the science level. But for you to take a smart history, it is required to qualify the wet cough in a way, or you can tell it is not a dry cough. You need not have to tell it's a wet cough, but you can comfortably try as a postgraduate. It's like a lawyer. You can't prove this, you prove other way around. How can you prove that it is not a dry cough? See, probably if you ask me, I'll ask a question to you by which I'll elicit, Arti, think that you are a mother. If I ask you these questions, you tell me, was the cough louder or softer? Wet coughs are often soft. The dry cough is often bizarre and loud. I don't know. Are you getting my point? Somebody
Yes.
even in that third room can hear from the first room a dry cough. Whereas for a wet cough, only if you sleep next to the baby, you would hear. I don't know. Are you getting my point? This is very, very important. This looks like little too much for you, but if it is too much for you, forget it. But this will help you in life. To try to get small tips like this, which will help you to qualify at the age at which it is too difficult to get a history. This is important. Or what is the color of the vomitus following cough? Suppose it is blood tinged, it cannot be dry. Or I would say if it is brown or if it is green, I'm not in this age group, but anywhere, you understand my purulent, they cannot be dry coughs. Dry coughs often produce that mucoid, whitish kind of sputum. That's very important. I think that somewhere, I'm not expecting at this age, but you must get that history. The first lesson for you is how to identify the cough. Second is ask the mother to video record in the smartphone and actually listen to the cough than her version about wet cough. When mother may hype or or play down, suppose if she doesn't want too much of investigation, she may say, no sir, little is there. Got my point. So therefore, always you be objective in this. Second point, which is important, is failure to gain weight. I would like to keep it very brief by telling you that this is a red flag. That means whatever pathology that the child is having, which is producing the wet cough, is also causing failure to gain weight. Beyond that, let's not discuss further. You understand? Failure to gain weight is very, very important. Be it a lactation failure, primary or secondary, but there is a reason to believe it is secondary because there is wet cough, not necessarily primary. Some of them would equate the sputum to whitish in color. They will think that by giving more milk, they will get more white sputum out. I'm not knowing about Tamil Nadu better, but I certainly know some parts of the country, including Karnataka, where they feel that whatever you feed will come out in the same color as sputum. The whitish milk will come as whitish sputum. I'm sorry. These are called as beliefs by the parents. Don't worry about them. But my point is, please ask about the color if at all you can, because that gives some clue. Now, let us come to closing. You have one solid presentation, that is wet cough, right? When you have a wet cough, the differential diagnoses are very less. Now tell me, what is the first diagnosis that came to your mind before you would ask for greasy stool? At 3 months of age, if somebody has, it can be an antenatal cause, or it can be intrapartum or postpartum or little later post-neonatal. You understand? Various causes. It could be congenital defects in the airways. It could be congenital disease of the heart. It could be congenital disease of the lungs. It could be anything, but not tuberculosis or foreign body, which can cause a wet cough. For a foreign body to cause a wet cough, it has to be not inhaled at 3 months of age. It should have been inhaled much 1 or 2 months earlier to 3 months. For it to have large foreign body, for it to get a lot of infection endobronchial and produce a wet sputum. Are you getting my point? So therefore, don't link that, don't bring in that foreign body at all. Dr. Murugesh nicely pointed out, and I would compliment him for bringing that point out. Now, we have got a process. What is the age of onset of illness, Kritika? Age of onset of symptom is 3 months. What is the age of onset of the disease, according to you? There is a difference between the two. Presentation has come at 3 months. When the disease might have started, according to, make a guess, no problem.
Arti, while the child
sorry,
comes.
Arti. Sorry, I changed the name. Sorry, beta.
No issues.
Sorry, Kritika only is coming to me. Arti, you please tell. No?
Sir, symptoms started from 3 months of age, but the illness would be started from birth.
Probably, isn't it? For somebody to get failure of weight gain at 3 months of age, illness cannot start one day before. It has to be there. So now having understood, suppose the illness starts at 6 weeks, 3 weeks, 4 weeks, I would strongly think of a congenital heart disease first. Because with repeated respiratory infections, there will be wet lung, which is most common, left to right shunts or otherwise. This you cannot exclude on history. Nor your feed rest cycle, which you never presented. Did you present? I'm sorry, I don't know if you would have passed away in the history. No, if you would have presented, fine, but that's the first thing that comes to my mind. That's important. That's to be excluded in examination, which will come to that later. Or you have told that the patient is not on any anti-failure drugs. Probably it would take a smart pediatrician to even auscultate and do a couple of tests like 2D echo, which will not take away his time. So that is my first presentation. Next point is that it's an airway disease. Cough it talks to you that it's an airway disease. And where? Is it a central airway disease or a distal airway disease? Now, my question is, you never told about breathing difficulty.
Sir, no breathing difficulty, sir. I mentioned.
Now, what does that mean? What does that exclude? Now, breathing
so that
difficulty
excludes
would...
heart.
One. Next. Even small airway diseases. Please read about what is called as SCAD, small airway diseases. Most of the small airway diseases would produce breathing difficulty. It can be even airway, but distal airways like bronchiolitis, etc., would produce a breathing difficulty. Or I would say with dyspnea, breathlessness, whatever words you want to use. And you should take the history of work of breathing from 3 months of age, not just the cough. It's not, they may not describe breathing difficulty because the mother won't feel the difficulty. You understand my point? Only thing the mother can observe is a respiratory distress in the form of work of breathing, which you can always ask. Was there indrawing of the chest? Was there recession? You understand? Couple of questions. Sweating. These are the questions that you would ask. I think, but for this, the rest of the case was smooth and straightforward. You nicely brought out the pointers to multi-system involvement, greasy stools, wet cough. Somebody is taking 26 grams for 23 grams of protein requirement would straight away give me diagnosis, because nobody in India would take so much of proteins. Yeah, you might have taken n number of cases in the history. If somebody is giving such high protein diet, it means that the child must have been diagnosed and put on appropriate therapy, probably some replacement for pancreatic enzymes or so on and so forth, which I'm not going to ask you at the history level, but there has been some therapeutic intervention also, which I could see that must have started. That's all right. Now, any other cause that you would like to ask? This is just for completion, not related to this case. Is there drooling of saliva? Because sometimes this tracheoesophageal links would also give rise to some kind of excessive salivation, vomiting, aerodigestive symptoms. These are some of the questions. Abdomen was flat or not. Was there any other congenital abnormality, especially neurodevelopmental abnormalities that can produce lot of respiratory diseases like regression of milestones, which can give rise to what's called a gastroesophageal reflux. These are the diseases which can repeatedly insult the lung through the stomach contents and therefore would produce a wet cough. So you need to separate persistent disease with intermittent episodic presentations or continuous presentation that you have done nicely well. And I'm done with the current thing. Probably some more details about the sibling death would have been very nice. If it died of the similar illness or non-similar illness, that much we wanted to know. You didn't highlight that point. Similar illness or non-similar?
Sir, the child had two male siblings deaths, sir. First was due to salt loss and dehydration. And the second sibling was had poor weight gain since birth, but he died of adverse events following immunizations.
Okay. Now let us think this will be a cystic fibrosis, because from the way you have presented, there is nothing secret now. Horoscope is open. But my point was, do you think the kind of genetic mutations you are going to get, are they going to be simple or are they going to be really horrible? Because there was one death, early newborn or post-neonatal presentation. So therefore, the presentation, especially the variant of cystic fibrosis that you would be seeing, not just cystic fibrosis, the variant would be a difficult to manage because and to treat also. You understand my point? It all depends on not just disease. See, as postgraduates, you must remember that there is a disease and there are variants of the disease. That means you can get a milder disease, you can get a moderate disease, you can get a severe or lethal disease. So that's also important for you. And as examiners, we'll be looking at how would you grade the illness, not just diagnose the illness. So you should be able to present this. And I think that sums up the summary. Dr. Murugesh, you want to ask anything else? We'll go to examination.
Yes, Aarti, actually this
Yes.
child you are now at this point of time, you're seeing at the age of 5 years. So now it is almost the diagnosis is straightforward, looking at your face that with every complaint and all these findings, it's all looking like cystic fibrosis. But like Sir told, if you are going to see the same child at the age of 5 months, with just a history of 2 months of wet cough, failure to thrive, at that point of time, what will be your thought process? How will you approach that case? So that is the main learning point, because cystic fibrosis, how early you are going to diagnose, that is what is going to decide the prognosis. So at that point of time, how will you approach this same child? If it's come to you, what will you do? What are differential types? How will you rule out a congenital heart disease? Any clues in this? Failure to thrive, wet cough? Which one?
Sir,
There's one point you have mentioned, which actually says it is not a heart disease.
Sir, no hurried breathing or no difficulty in feeding also, sir. And no
Actually, the
cyanosis.
cystic fibrosis patients, in spite of the weight loss, they have very good appetite. In other illnesses, if you see, there will be a poor appetite also will be
Loss of
associated.
appetite
Actually,
will be there.
in this particular condition, actually, what you mentioned was, Sapli, you have mentioned that the child had a very good appetite, actually. So that is
Yes.
one point, right? So something to say, right? So what are other differential diagnoses you will think out at that point of time? Whether the fed cause associated fever, was there any
Sir,
fever associated? What are other differential diagnoses? 2 months of
yes,
cough, frequent cough episodes. What
yes,
are other
sir.
things you have to rule out?
Aarti, I will be your internal examiner to help you. Do you think of immunodeficiency?
Yes, sir. Yes, sir. I will think of
Which type? Dr. Murugesh won't be
primary,
happy. Primary,
primary
T or B
immunodeficiency.
cell, or
Sir,
combined.
usually B cell deficiency present after 6 months of age, since there is a maternal antibody
Excellent.
transmission.
Why? Because of protection with breastfeeding, and at the time of weaning, you will have that immunoglobulin compensation by breast milk is gone, and that's the theory that you are going to tell me. Why not combine T and B cell versus T cell? I think you work on this. You got my point. Now that's the catch. Second thing is, you would be at 4 months of this age, this child was hospitalized, right?
Yes,
Now the
sir.
question is, what is the type of antibiotics that were used? How long the antibiotics was given? How long it took for the child to recover the illness is a very important clue for immunodeficiency. An immunocompetent child with a existing lung disease like, let's say, cystic fibrosis would recover in 5 to 7 days. Okay, you can take another 2 days. But immunodeficiency child would require 2 weeks. Sometimes you cannot, you may have to use multiple antibiotics, or you may have to use unusual antibiotics. You got my point. Or that there'll be a lot of scratching. Oh my God, what shall I do? You understand my point? It would pose a lot of managing problems, not diagnostic problems. You understand my point? That's the catch. Whereas chronic diseases like this, flare-ups of any disease would not last more than a week. A flare-up is a short one. It flares up and goes back in most of the diseases, although not necessarily, right? Okay. Now that's the answer that you would give. One help I did you was immunodeficiency. Any other disease?
Sir, aspiration can be suspected. Pneumonia, sir.
At what level? Aspirations happen at 3 levels. Dr. Murugesh, I'm helping her because I declared as internal examiner. No, I'm helping her.
Yes, sir.
Aspiration can happen at 3 levels. One upper level, laryngotracheal. That means you should have laryngeal cleft lip, palate, all oropharyngeal, orolaryngeal, laryngopharyngeal, congenital abnormalities, which can give rise to aspirations. These patients will have drooling of saliva, protruding of tongue, peculiar postures. Mother finds starts removing the breast and starts feeding. Dr. Somsekhar would like my explanation. Most of these children have difficulty in latching, so on and so forth. You understand? Milk regurgitates, so many things happen. You understand what I meant by oropharyngeal symptoms? They would adopt a particular posture to sleep. There will be snoring or there will be stridor. Most of these symptoms would come in the upper level of aspiration syndromes. Mid-level escapes because the tiny tracheoesophageal fistulas, they just present as lung infections, and it would be a surprise by your bronchoscopy or esophageal evaluation that you would discover. Lower level reflux is a big, what we'll say, pender of box of full of controversies, whether it is a natural purging or burping, or whether it is natural efflux or a reflux physiology but becomes pathological. It can never think of a physiology here because there is failure to thrive. You got my point? If there is spitting but with failure to thrive, it cannot be physiological. If it is lower, then you would ask for the color, especially bilious, non-bilious, etc. Whether there is a pre-existing condition like a neurological disease or a musculoskeletal disease, etc., that would predispose for a reflux. Even ask about diaphragmatic hernias. I mean, you can't get those histories, but keep all these things in your mind. This is 3 level of aspirations, and most of these aspirations keep getting admitted again and again, but there will be some temporal relationship between feeding and respiratory symptoms. This is important. And how as smartly you ask as a postgraduate will decide whether you get a gold medal or just a pass. Okay, go further. Dr. Murugesh, other questions for her?
Yes, sir. You can proceed, sir.
We'll go to examination.
Yes, sir.
Dr. Kritika, you can tell us when the time is over. Anyone
Sure,
of you?
sir. Sure, sir.
Oh,
Yes,
please,
sir. I'll
please
remain
tell
this,
us.
sir.
We'll go on discussing. Otherwise, you have to edit us.
You please take your time, sir. You please take your time. You please take it.
General examination.
Coming to the general examination.
Now,
Child was...
now Aarti, I wanted you to show the variations in the presentations now.
Yes, sir.
Yeah, now try this exercise.
Coming to the general examination, child was examined in a well-lighted room with a comfortable position, and he was alert, comfortable at rest, and he was very playful and active. He was moderately built and nourished. He was afebrile at the time of examination. No pallor, icterus, cyanosis, clubbing, or lymphadenopathy. Vitals, pulse rate, 95 per minute.
Excuse me, sir.
Yeah, please.
Sir, can we have a few remarks by Dr. Balasubramanian, sir?
Yes, please.
Regarding the summary
at the level of history. Okay.
Yes,
On my screen, I'm not able to see everyone.
No.
I could see you next to me, so I was asking you. Please, sir, Balasubramanian, sir.
Yes, sir.
Gauri
Yes,
Shankar,
sir.
all of you can, comment.
No, when Subramania is batting like Tendulkar,
No, sir.
just simply watch, admire. Excellent. However, Dr. Aarti, it's an excellent presentation. You did very well. Don't get rattled. We examined Subramania. Examiners like Subramania are always there. Examiners like Balasubramaniam also are there. He wouldn't rattle you like this. A few suggestions for improvement other than what you did. You did a very good job. Of course, he mentioned that, but I wanted other postgraduates also to get the message. See, what you did, you presented 2 symptoms. One, you said wet cough. Second is that lack of weight gain. And then, for about 5 minutes, you only talked about an antenatal period, which is of no relevance. So never start your presentation without any facts. So if I were you, I would not have talked about antenatal period because nothing has happened in the antenatal period. There is no clue to diagnosis. Am I right or not, Dr. Aarti?
Yes, sir.
Yeah. So I want all the postgraduates to remember this. Don't start from a very uninteresting 0-point history. Normal antenatal period, just don't mention at all in this case. It's normal. That's all. That is comment number 1. Second, I want to ask you, you had said that 3 months only the problem started. Does it mean that the baby was well up to 3 months? Always, you should know when the disease process started manifesting. Do you
Okay,
get my
sir.
point, Dr. Arti? Do you think it started manifesting at 3 months or earlier?
Any
Sir,
history of any weight records during vaccination point? That time you can easily find out, no?
Yeah.
yes, sir.
45
Was
days
this baby
vaccine.
completely normal at 3 months?
Yes, sir. He was normal till 3 months of age. After 3 months only, he developed symptoms, sir.
In what way it
And
was normal? Was the weight gain normal? Was the development normal? Everything was perfect up to 3 months? I
there was
don't think so. I don't think so. Something must have happened. I don't think it will start at 3 months. There must have been some history, particularly weight gain from 0 to 6 months would have given you a clue that this problem is congenital rather than acquired. That's why I'm harping on this. That is 2. Third, you can still defend yourself saying that it's a wet cough. If the mother says, doctor, when the child is coughing, it looks like there's a lot of phlegm. Intelligent mothers will tell you that, and you can identify the wet cough from the history. It's not impossible like what Dr. Subramania said. You can identify a wet cough quite early. And your first symptom is cough. Now child is 5 years. And what happened to that cough? Did it come and go? Did it remain the same? Did it worsen? You never mentioned that. What happened, Aarti?
sir, he had a episodic worsening of cough, sir.
In
In
between,
between period, he
is
was
he completely all right?
in between he had a cough, sir, but not
That's
that
very,
much episodic
no,
worsening.
that's very important. That should have elaborated, because somebody who has a cough which comes and goes is likely to have a different disease process, which may be periodic, whereas somebody who has a cough which is persistent, which is worsening, with frequent exacerbations occurring more than in the beginning, will always tell you the disease is chronic and progressive. I think the course of the cough should have been described, indicating that it is a relentless progression of a disease. Okay, that
Okay.
is it. And third, this child, you said from the history, there is failure to thrive. Always, failure to thrive, when it occurs, is very, very useful. I want to tell the postgraduates, you ask yourself whether this failure to thrive is because of too little in, too much out, too much is required, or too little is required. Too little is utilized, I'm sorry. So again, I'm repeating it, too much in, too much out, too little is utilized, too much is required. Which group does this child belong to, Dr. Aarti? From the
Sir,
history.
too much out, sir.
Pardon?
Too much out, sir.
Where?
Malabsorption. He's losing all the fat in his stools, sir.
Do you think that's the only reason? Do you think that's the only reason? I'm
Along
saying
with the
there is one more
increased
reason. I'm saying there is one more reason.
recurrent respiratory tract infections, sir.
Too
Increased
much is required.
utilization.
Too much is required. Every time the child gets an LRI, the basal metabolic rate goes up, the requirements go up, the intake comes down. So all the three are there. Too little in. See, first what you said is correct. Too little in and too much out, diarrhea, and too much is required. Too much is required, like thyrotoxicosis, diabetes mellitus. This child requires huge amount of calories because of the chronic respiratory disease. And finally, always when you start a symptom, you should say what happened to that symptom and what is the current status. Okay. Now, one
Okay,
last
sir.
question. What was that episode of dehydration, vomiting that caused a problem that presented so early at 3 months? What do you think happened?
So the child had vomiting, sir. So
No.
for
What
the
do you think
child,
was I want you to make an intelligent guess of what that episode was. Do you think simple vomiting? What is the cause for the vomiting? Do you think simple vomiting caused so much of problems? Okay. You should have asked one more question. The question of polyuria, frequent. Did you ask the parents whether the child was passing so frequently when that episode of vomiting occurred? Why am I asking this question, Dr. Aarti? Will that give you a clue? Suppose they say that the child was, in spite of vomiting, child was passing urine every hour.
Sir, Bartter syndrome, sir?
Bartter-like presentation. I think at no point of time you collected that history of polyuria, frequent urination, which could have given you a clue that it might have been a Bartter-like episode. Even these episodes of hospitalization occurring repeatedly due to dehydration, you could have got that history of polyuria in the presence of vomiting, indicating that there is a renal tubular leak, renal tubular dysfunction, which will fit into a diagnosis of cystic fibrosis with pseudo-Bartter. Otherwise, your presentation was excellent. Thank you. Please proceed.
Thank you so much, sir.
Subramaniam.
Thank you so much, sir.
Thank you, sir. Sir, it is nice and pleasure to listen to you. When you were discussing couple of points that came to my mind, Aarti, I would pass it on to you. One is that a disease won't start with a wet cough. There is always a dry cough preceding the wet cough. You can't get an etiology that is causing bronchiectasis directly cause wet cough. There will be a phase of dry cough and then it turns into wet. Are you getting my point? Any disease, even
Yes,
for
sir.
that matter, protracted bacterial bronchitis as a diagnosis of explosion will start with first 4 or 5 days dry cough, only later on you will start getting the wet cough. Because first there is airway irritation and then there is hypermucus state that would be available. I mean, even in all the diseases that you are thinking of wet cough, there will be a phase of dry cough. You need to pick it up because there will be some confusions if there is an early inquiry by you in those diseases. That's one. Second, what if there was no cystic fibrosis diagnosed in this child? Then what you would have thought of? Let's say CF test comes negative with all the efforts. In that case, what would be important is asking about early neonatal period. Suppose if there was a respiratory distress like TTN or prolonged newborn course with oxygen dependency, etc., then you should think of primary ciliary dyskinesia as a diagnosis that would entertain the presentation of wet cough as early as 3 months of age. These were 2 points. Balasubramanian, sorry, I forgot to ask her. So therefore, I'm just asking her now. Aarti, you can proceed.
Yeah, only point against primary dyskinesia is that there was no cough in the first 3 months. Never any ear discharge, and malabsorption and repeated hospitalization. I mean, that for non-respiratory issues makes primary ciliary dyskinesia unlikely. Yeah.
Only thing that I was trying to tell you was this is like a textbook case. Suppose if it was not, then you would have had to have passed through all these things, right? All right, you proceed.
Yes. Thank you, sir. Vitals, pulse rate 95 per minute, regular rhythm, pulse volume good, which was felt in all the palpable vessels. Respiratory rate 26 per minute, thoraco-abdominal type of respiration, and there was no increase in work of breathing. BP 102 was 76, 84 of millimeters of mercury, which was measured in right arm in sitting position. Temperature 98.7 degree Fahrenheit, which was measured in axilla. SpO2 of 97% in room air. CRP 2 seconds.
Proceed.
Yes. Anthropometry has observed weight was 15 kg out of expected of 18 kg. So according to the
excellent.
IAP.
You skip now. We will save more time for discussions further. There is a failure to thrive, and as a postgraduate, I know you will tell all circumferences. Anyway, you are in final year, will not ask you. There are many cases that you can discuss these things. There is failure to thrive, right? Go ahead. Go ahead. I know you want to discuss here more because this is your strength. Okay, go ahead. Next slide.
Next slide. Okay.
Yeah, next. Yeah, you tell me the trend in the growth chart. This would be interesting.
After starting treatment, he showed some improvement in the growth.
Yeah. Now, in the growth charts like this, Aarti, this is not there in most of the textbooks. You can somehow continue the line and draw the trajectory back up to birth. You know that the birth weight was 2.8 kg. you have the documentation from 4 months of age, correct? With you.
Yes, sir.
You can
It's
link that
available
line
from
between 2.8 kilo to 4 months. You can at least link them, no? You can link it. You got the point.
Yes, sir.
Yeah, now don't do it. You do it at home, no problem. But just I'm trying to tell you. You need not
Yes,
have
sir.
to start now. You know the birth weight, all right. So don't leave the
Yes.
dots. Okay, fine. Go ahead.
Next slide.
Yes, sir.
Okay.
Coming to head to toe examination, head normal, eyes normal, head, ear, nose, throat normal, neck normal, extremities normal, skin BCG score present, no rashes or bleeds, no features suggestive of any vitamin deficiency.
No.
Coming to the rest,
No. Upper airway examination. You are doing next. Okay, fine. Fine. Go ahead.
coming to
Okay,
respiratory
fine,
system,
better. Because you are coming here, so
everything looks
therefore you.
normal.
Yeah. No, go back. Upper airways.
Upper airway, nasal cavity, normal. There is no any visible polyp. No nasal septum is in midline. No sinus or ear.
Agreed.
External artery.
Now, all the thing that I want to tell the postgraduates at this stage is not necessary that cleft lip, cleft palate, etc. should only be visible. It can be even subclinical and palpable. So you don't just be happy by seeing the continuity of mucosa. Actually, you should palpate and see if there is any dip. That's important. Okay. Other than that, everything else is appears fine. There is no visible polyp because polypectomy has been done. Septum is in midline is a good thing. That's because the polypectomy. What does that tells me? I mean, not at your level as a postgraduate, but at least as consultants, we should know that the polypectomy was often done for deviated nasal septum, where one side compensates for breatho-aerobics. You understand my point? So that when the nose is deviated to one side, the other side develops a polyp. So at least I will know that this polypectomy is not because of local factors. You got the point. That's very important. Okay, go ahead.
Here, external auditory canal normal, tympanic membrane purely white, oral cavity, good oral hygiene, no dental caries, tonsils normal, there is no oral thrush.
Yeah, in
Lower
tympanic membrane, if you are not seeing OME, see there is no otitis media, but in those cases where there is feeding issues or oropharyngeal issues or palatopharyngeal issues, usually the auditory canal will become full and they will have some sequelae and OME. Serous otitis media is a finding, not suppurative otitis media. If you find suppurative otitis media, then it will take you to towards the diagnosis of PCD, but not in this case. All right? Okay,
yes.
go ahead.
Lower respiratory tract examination, inspection, trachea appears to be in midline, apical impulse visible at left fifth intercostal space, 1 centimeter medial to the midclavicular line. Chest wall symmetrical, moves equally with respiration. There was no retractions, no drooping of shoulder observed, no sinus, scars or dilated veins, and there was no bony abnormalities. Palpation, tracheal position is confirmed to be in midline, and the apical impulse also confirmed, which was in the, over the left fifth intercostal space, 1 centimeter medial to the midclavicular line. Chest wall expansion 3 centimeter. During inspiration, it was 58 centimeter, and during expiration, 55 centimeter. Movement of the chest wall equal and symmetrical, and there was no chest wall tenderness.
So what is your conclusion? No, don't go ahead. At this stage, inspection, palpation, what is your conclusion? Okay, I will make the question simple for you. Is it likely to be a unilateral disease or a bilateral disease?
Sir, it is likely to be a bilateral disease, sir.
Okay, there may or may not be a disease, but if it is there, it will be a bilateral disease. That much is fine for me. You got my point. That's the line of, actually should have a good line of thinking, which is very important. So having symmetrical normal findings or abnormal findings, both would take you to a bilateral disease. All right, go for percussion. Percussion or whatever vocal frame it is, right?
Vocal fremitus, which is normal
Normal.
overall.
Next.
Percussion, which was also normal over all the spaces, resonant over all the spaces.
So it is taking away all the focal, or should I say peripheral, or lung lesions that you would get close to the chest wall, isn't it? Like effusion, whatever you percuss, whatever you feel, all those things are out from the discussion, right? It was not there even at the thought also. But sometimes it so happens in respiratory diseases, you would ask something, but when you examine, you'll find something else. That has happened to most of us. No, it is because not that mother has not told, we have not asked proper history, and many times we revisit the history after examination. This happens to most of us in basic practice. What happens is you would find something, then you will again go back and ask a couple of questions, and then you rewrite your history. That probably happens to you also after seeing chest x-ray. As a postgraduate, you must have asked a couple of more questions in history, isn't it? So it's very important that after examination, at any point of time, should correlate with couple of questions by revisiting the history. It's a very good skill and you need to develop that. All right, go ahead.
Auscultation, there was normal vesicular blood sounds heard all over the areas. And vocal resonance, normal bilateral, and there was no added sounds observed. Other systemic examination, cardiovascular system, S1, S2, first and second heart sounds here. There was no murmur. Abdomen soft, there was no organomegaly. Central nervous system, there was no focal neurological deficits. Coming to the diagnosis, so probably from the history and examination.
Beta, you did not tell about abdominal examination.
Soft and there was no tenderness and no organomegaly.
No, okay, but I agree with you, but you should give equal weightage to the examination of abdomen, having got early that bulky stools, etc. Did you do a rectal examination, which is difficult for you to do? At least comment on whether there were fissures, whether it's alternating diarrhea, constipation, whatever. You understand my point? We would be interested to know if there are any anything that is little more than at least what you could present, right? That's something which you would be interested to know. Now you can't pass it off with one line, but that's all right. Multi-system disease it is. Therefore, you have described one full table of normal vocal fremitus. Therefore, I expect at least 2 lines on the examinations of all the systems, knowing that this is a respiratory presentation of a multi-system disease. So give more importance, 1 or 2 lines. All right, beta, no problem. But fair enough. Go ahead. Go ahead, no problem.
Diagnosis, chronic suppurative lung disease with malabsorption, with pancreatic insufficiency, with underweight, which was ingrown.
Okay. What is the cause of chronic suppurative lung disease? Is the diagnosis, right? Chronic suppurative lung disease is a presentation or a diagnosis? Chronic suppurative lung disease, is it a presentation or a diagnosis?
Clinical findings, what is the supporting of your diagnosis, chronic suppurative lung disease? Is there any clubbing?
So there was no clubbing, sir.
No
There was
lung examination is normal.
Yes, sir.
So you can say chronic lung disease with wet cough rather than using the word suppurative lung disease, malabsorption, pancreatic insufficiency, and a catch-up following a failure to thrive as the presentation of an underlying diagnosis, which is likely to be cystic fibrosis. You can commit here. There's absolutely no problem.
Okay, sir.
There is a difference. All the postgraduates and probably the young consultants, you should remember, should not mistake a presentation for a diagnosis. Anemia is a presentation. Pallor is a presentation, but not a diagnosis. Iron deficiency anemia is also not a diagnosis. Iron deficiency anemia due to chronic GI bleed is the diagnosis. I think diagnosis is something like you need to dig and reach out. You understand my point? And not necessarily by investigation. Even at the history and examination level, you need to narrow down and put the probabilities. See, here you should say the pointers to the diagnosis are chronic suppurative lung disease, malabsorption, pancreatic insufficiency, multi-system presentation with failure to thrive. Probably I can narrow it down to the level of cystic fibrosis. You can even commit to that extent. There is absolutely no problem, Aarti. Nobody is going to deny. Okay, go ahead, no problem.
Yes. Yes. Coming to the investigations.
Murugesh sir, do you want to ask any questions?
No, let her proceed.
Okay, sir.
At 3 months of age.
SBS, sir.
Yes.
Yeah, please go ahead. When I say go ahead, others can interrupt. No problem. I'm just trying to finish off in time. I don't know how much
Sir,
of time
you can
is
take your
allocated.
time. You can take your time.
No issue, no issue, ma. I will not know. That's why I will tell. Go
CBC
ahead.
is any clue for any immunodeficiency? You'll see. I think at this point on 3 months of age, and the child comes when immunodeficiency is also a possibility. Any clue you can get from the total CBC?
Yes, sir.
How you
Absolute
rule out
lymphocyte count.
Yes.
Absolute lymphocyte count, sir. That was normal in this kid, sir.
What will be the cutoff like?
Less than 3,500
Or vanilla
lymphocytes.
suspect, or could be different. Vanilla suspects kid with the absolute lymphocyte count.
But I open that Nelson on ChatGPT, it will tell you 1,500.
Okay.
Nowadays, your generation next should open GPT quickly. Okay. No problem. Murugesh sir, I have promised her to be internal examiners.
Okay.
So, accept my apologies.
SPS, sir?
Yeah.
Yeah. Can you go to the previous slide, Dr. Aarti? Previous slide. Yeah. First is, I'm tempted to ask you, what are the chronic suppurative lung diseases you know of? And what suppurative lung disease did you think of in this child?
Sir, chronic suppurative lung disease is classified into based on cystic fibrosis and non-cystic fibrosis related diseases. And in this kid, I would like to offer cystic fibrosis as a diagnosis.
No, what are the non-cystic fibrosis chronic? What are the various chronic suppurative lung diseases? Name them, and which chronic suppurative lung disease is this?
Like bronchiectasis is related to infection, any localized or foreign body.
No, don't worry about etiology. No, Dr. Aarti, please don't worry about etiology. I'm asking an exam question, Viva question. What are the chronic suppurative lung diseases you know of? 1, 2, 3, and what did you suspect in this child?
Yeah, please be louder.
Primary ciliary dyskinesia, immunodeficiencies, primary, secondary.
So you told something before.
Primary ciliary dyskinesia is not a chronic suppurative lung disease. It's only bronchiectasis, lung abscess, pulmonary gangrene, and chronic empyema, chronic necrotizing pneumonia. These are the ones which are called as chronic suppurative lung diseases, right? So in this child, what did you suspect? Aarti? Hello?
Yes, sir. Yes, sir. Since it is a bilateral disease, I would like to offer like aspiration related or primary or secondary immunodeficiencies.
No. Why are you getting into trouble by aspiration? Aspiration disease, see, two things. Aspiration disease is a dustbin diagnosis in this child who doesn't seem to have a neurological problem, right? Who doesn't seem to have any congenital anomaly from the history and on physical examination. Why are you thinking of aspiration syndromes? Aspiration syndromes will be in neurologically debilitated children with myopathy, neuropathy, central nervous system disease, airway anomalies, not in a child who's developmentally normal, who doesn't have any neurological impairment at all, I think you should straight away say, I am suspecting probable airway disease because there is cough. You started with wet cough, and the airway disease which causes chronic suppurative lung disease is bronchiectasis. That's all. That's the answer. Second, how did you make a diagnosis of pancreatic insufficiency clinically in this child?
Sir, clinically, he had oily stools and poor weight gains
But
in spite of normal appetites.
No, poor weight gain can occur in any malabsorption, isn't it? Not necessarily pancreatic insufficiency. What made you diagnose pancreatic insufficiency? I'm asking.
Sir, oily, bulky stools, sir.
That can occur in any steatoria, and the steatoria may be due to any small bowel malabsorption. So you can't be very sure. You can't be very sure. You should only say that there is a small bowel chronic malabsorption with steatoria. Okay.
Okay, sir.
You can straight away come to one of the most common causes in a child who has got a respiratory problem is pancreatic insufficiency. Okay, that's what.
Yes, sir.
And last is, I'm going to ask you another question. The same child, if it is not cystic fibrosis, with bronchiectasis, with malabsorption, okay, can it be some other chronic disease which is inherited, which can involve the bowel, which can involve also it can present like immunodeficiency, which can present like immunodeficiency, present like failure to thrive, some thyroid problems also. I am giving you a clue. Okay. One of the other diagnoses I would consider in this child is IPEX syndrome, which can present with small bowel malabsorption, which can present with failure to thrive, recurrent infections, and IPEX syndrome, hypothyroidism. That also is a distinct possibility in this child. That you have to keep in mind. That last is, I'm surprised, I'm sure Subramania would agree with me, 5 years old, classic cystic fibrosis, if you say clubbing is not there, I'm really very, very surprised. Yes or no, Subramania?
I agree, sir. But was the treatment by Dr. Anthony Terrace was so good that the clubbing got reversed? This was in a lighter vein. Now that the child is eating 28 grams of protein, which I am not eating, I am very surprised. I mean, this is a very wonderfully managed baby.
Yes.
Aarti, you have to tell sir whether there was clubbing or no clubbing, and what were the things done by you, not just seeing, how did you exclude? Did you really look into the clubbing is what Dr. Balasubramanian sir wants to know, because it is a forgotten art.
Sir, how to look, can I get the question, sir, once more?
How do you diagnose clubbing very early or minimal clubbing is what Dr. Balasubramanian sir is asking. Because you didn't observe, obviously it means that there can be minimal clubbing that is missed. Balasubramanian sir, I'm reframing the question for her.
Sir, fluctuation of the nail bed, sir. That can be.
Did you check?
Yes, sir.
You checked. Sir, we can trust her, sir.
I don't know. I'll have to check with Dr. Anthony Terrence whether there is really no clubbing. I would have expected clubbing in this child at 1 year of age itself. See, even if the lung disease is not severe, in the presence of malabsorption, chronic problem, definitely I would have made out clubbing in this child. I'm 100% sure. Anthony, your comments, please. Are you sure there is no clubbing, Anthony?
Sir is not there.
Okay.
Yes, sir. Sir has come.
Dr. Anthony,
Balasubramanian sir, I was just googling through ChatGPT and I was trying to see if clubbing can be reversed. I'm reading from GPT, which is unreliable. Sometimes it can be reversed if underlying conditions such as lung disease, heart disease, or cancer disease.
Cyanotic heart disease, surgery done, clubbing might disappear.
if lung disease, heart disease, or cancer is successfully treated, sometime it can be reversed. That's what I'm reading from my screen. I will just try to see some more references. Quickly, I was referring. Anthony, your comments.
Sir. Thank you very much. I think very good teaching from stalwart teachers, Dr. Subramania, Balasubramanian sir, and Murugeshan. Lots of learning points. And, some of our patients with bronchiectasis, very unusual, it doesn't have clubbing. Not all our patients have clubbing, sir. In PCD, we have noted that clubbing is not there in almost 50% of patients who have bronchiectasis. But cystic fibrosis, most of them will have clubbing. But this patient didn't have clubbing, sir.
Very surprising. No, of course.
Is clubbing geopolitical in your area? Not seen. Elsewhere it is seen. Probably fine.
Actually,
Anthony, you are one of my teacher who taught me to keep one adrenaline ampule for anaphylaxis every time in the airport. Ever since that day, all my students are keeping one dose of adrenaline always ready for anaphylaxis. Why you compliment the teachers? You are one of our favorite teachers.
No, I think
we respect you a lot.
Lots of perspectives on how to express yourself, and I think you have to be very lively in examination. That's very, very important. That's a very important point actually to mention. And sir, like Balasubramanian sir said, you have to be very clear with the diagnosis. I think she showed me the slide, there was no pancreatic insufficiency. But therefore, pancreatic insufficiency you can only diagnose after testing. You can't make a diagnosis of pancreatic insufficiency clinically. It's very difficult. But the presentation was good and lots of learning points from the teachers as well. Thank you, sir. Thank you.
Finally, one more comment, Subramania and Anthony. Yeah. The most foolproof way of ruling out clubbing.
Okay, sir.
I know one crazy professor who had written an article. You can put a POP cast on the finger of the child and measure the angle correctly.
Okay.
No, there's a paper on it. You can POP cast, then cut it open, measure the angle accurately, and then you should conclude whether there is clubbing or not. It would be worth doing it in this child, Dr. Anthony.
Yeah, sure. And another patient which I saw, just like cystic fibrosis, had bronchiectasis, pancreatic malabsorption, and had neutropenia. It's like a teenage girl. It was a Swakman-Diamond syndrome.
Okay. Balasubramanian sir, on that note, I think instead of cast now, if I were to be crazy, I would have developed an app in which you post the fingers photographs, and then that app will say whether there is clubbing and which grade it is. Nowadays, I think with the digitalization, everything is possible. It can even measure the angle of nail to the rest of the fingers. All these things are possible with AI. So probably some days later, somebody would come out with even an app to diagnose most of these conditions like forgotten art, which has been going through. And it is possible. Digitalization can compensate for objectivity of clubbing, but it cannot detect fluctuation.
Yeah, but the important take-home point you have mentioned, sir, like children with respiratory disorders, it's very important to examine the hands. You should not miss that.
Yeah.
Examination of hands,
I would be
especially for
interested
clubbing,
to
is
see
very
for
important.
evidence of megaloblastic anemia in the finger, hands, etc. when there is a malabsorption like this, because ileal or non-ileal, whatever. You can just get on to that. Arti, you can proceed.
Yes. Coming to the investigations at 3 months of age,
sir, we have 10 more minutes, sir.
No, we'll wind up before that. Don't worry.
Okay.
Blood counts were normal with a normal limit.
Okay.
And at 4 months of age, he was hospitalized for salt loss and dehydration. So he showed metabolic alkalosis with electrolytes showing hyponatremia, hypokalemia, and hypochloremia. So, and they have done renin and aldosterone also, which were elevated for the age. And at 4.5 years of age, we have done one X-ray, that is 1 year back. So that was normal.
Okay.
And
next.
Dr. Arti, I don't think X-ray is normal. Please go back. I don't think the X-ray is normal. It is showing nearly like tram line appearance in the right lower lobe and also behind the heart. Dr. Anthony, please, you know better. I won't report this as normal X-ray.
Okay, sir. I will come to the rescue of Anthony because he is not there.
Okay.
I would just read the X-ray for you, Aarti. To come to your rescue, you should start from trachea. Probably the neck of the child is deviated to one of the sides. That it's not tracheal deviation. Because tracheal deviation will start with normal in the neck, but later on deviate. This is starting from one end like this. Probably this you don't have that upper half of the head. Therefore, I would not take it as tracheal deviation. Actually, tracheal indentation or curving is more important than actually a type of deviation in the trachea. Knowing that it is a bilateral lung disease and with no apparent abnormalities of mediastinum and lung, this alignment of trachea, I would take it as positional related to head and neck. Next point is I would come to the hilum and carina. Carinal angle is normal. Hilum appears to be fine. And chest is actually, chest X-ray is showing symmetry. No cervical rib, no thoracic abnormalities, no soft tissue abnormalities, no air under the diaphragm. There are no calcifications. Extra thoracic tissue appears normal. Aarti, I'm telling so many points. If you start speaking like this, exam will give you more and more marks. You should start speaking on everything that is seen in the X-ray. And then you come to the lung fields. You go zone by zone. Upper zone, bilaterally symmetrical. Bronchovascular can be traced up to nearly 2/3 and beyond 2/3 of the lung fields. This is what Dr. Balasubramaniam was referring to. Mid-zone, compare right and left. Mid-zone also, you trace and track that bronchovascular markings that you are seeing. Those markings are going beyond 2/3 of the lung fields. Are you getting my point? Generally, there are no criteria in children, but in adults, they say for increased or decreased vascular markings or these markings which spread from, you can see my hands like this, go up, go to the periphery. If it is beyond 2/3 of the apparent lung fields, then it is increased. Or if you find a vascular marking where you are not expecting a vascular marking, then also it is a sign of inflammation or increased blood flow. Get my point? Generally, when you move away from the hilum, you don't see most of the vessels because vessels become thin and thin, not to be seen. When you come closer to the hilum, vessels are thicker in caliber that you can see them. It is a very simple physiology that you need to understand. It's a good inspiratory film. Now, my question is whether there is air trapping bilateral, which is suggestive of a bilateral small airway disease. This is very difficult because a lot of X-rays when we report, even if there is a bilateral minimal air trapping, we cannot appreciate it compared to a good inspiratory film. But now if I count the number of ribs, 1, 2, 3, 4, 5, 6 ribs, that means it's a very good inspiratory film, or it could be an air trapping. You got my point. A 5-year-old can cooperate for good inspiration when I will take it as physiological, or if it is taken while he is casual, probably it is possible that there is an air trapping and flattening of diaphragm. The minimal scoliosis that you are seeing is postural, and I can relate it to the position of the neck and the way in which the patient is there. What Dr. Balasubramanian is asking the question is whether these shadows that you are seeing are symmetrical and parallel. You know, in bronchiectasis, you will get that parallel shadows, which are called as tram tracks, like railway tracks. So, what Dr. Balasubramanian, sir, can you see my cursor? I don't know, because you are the host. You can show those retrocardiac, 1 or 2, and even in the right middle lobe, couple of them are seen. But what I wanted to see as an evidence of bronchiectasis is signet ring appearance, which is not there. And secondly, the ratio of the pulmonary vessel to the airway caliber. If you think that the airway caliber to pulmonary artery ratio, which is called as PA ratio, is 1 in adults, and in children, the accepted values are 0.8. That means to say the vessels are larger than airways, and vessels will be 0.8 and airway will be 1 as far as the ratio is concerned. You got my point? Because lungs likely to be more vascular and less aerated in children compared to an adult. So if I take the PA ratio also, it appears to be apparently normal, and therefore whatever you are seeing those symmetrical tram track like appearances are actually on the ribs and retrocardiac, so they are seen well. So I would say I would give importance to that excellent point from Dr. Balasubramaniam sir. This is a limitation of chest X-ray in coming to a final conclusion, because the investigation of choice for ruling out or ruling in a bronchiectasia is always a CT scan chest. I think Dr. Anthony, Dr. Murugesh, Dr. Balasubramaniam can comment, because I just taught her how to read a chest X-ray. Beyond that, that's you can see all my YouTube Sarthi on chest X-rays in children and interpretation. It runs for 1.5 to 2 hours. You can go through the YouTube videos. But over to Anthony. Any other X-rays you saw in this child which was suggestive of anything else? Because you have only one X-ray with us.
I think, sir, I think it was a good observation by Dr. Balasubramaniam. Actually, on the right, like lower zones, you can see, parallel shadows.
Yeah.
There is no tapering towards the end. As you mentioned, that's a very important point. If you see the bronchovascular markings in the peripheral 1/3, probably that might indicate the child might be having, bronchiectasis, but you can confirm only by doing a CT scan. That's a very important thing. Even if you have a normal X-ray, if the patient is having chronic wet cough for more than 2 months, it's important, even with a normal X-ray, how to do a CT scan. But as you said, signet ring appearance, cystic lesions, this might suggest, along with the tram track appearance, bronchiectasis on a X-ray, but you have to confirm it by doing a CT scan.
Yeah, for the sake of postgraduates for the examinations, if you are asked what are the X-ray findings you can get in bronchiectasis, you should give a cautious answer. The X-ray may nearly look normal. A normally looking chest X-ray does not rule out bronchiectasis. 1. 2. The most common findings are areas of increased vascularity, like in this, both the lower lobes. 3. Tram line appearances. 4. Signet ring appearances. 5. There may be areas of fibrosis secondary to multiple episodes of pneumonia and the parenchymal loss. Okay. Last but not the least, you may find cavitatory appearance in the most severe forms of bronchiectasis. The best way to remember bronchiectasis severity is CVS. Cylindrical is the least severe, saccular is the most severe, and varicose is in between. In saccular bronchiectasis, you may get even cavitatory lesions in the lungs. Okay, but of course the CT scan is the gold standard, but there will always be clues, and the most significant clue with which you can confirm bronchiectasis even in the X-ray is nothing but your signet ring sign, which is very rare. Thank you.
Arthi, only one thing. What is the interpretation of the ABG had posted, the 4 months of age? What is the interpretation of this slide?
Sir, pH showing alkalosis, sir.
Yes.
With low sodium, hypokalemia, hypochloremia, sir, and increased bicarbonate levels.
No.
Which type of alkalosis
No.
is
Anything
that?
it is suggesting it is towards cystic fibrosis here. How will you interpret? Which
Sir,
point?
metabolic alkalosis.
Yes, okay. Metabolic alkalosis can happen even in Bartter syndrome also. Like Balasubramanian sir told, in polyuria, there's going to be a Bartter syndrome. There can be a metabolic alkalosis. Which, when you see a metabolic alkalosis, what will be the next test you'll do?
Sir, urinary chloride levels we can check, sir.
Yes, good. So next thing you should say is the urinary chloride. Only with the urinary chloride, here it is somewhere around 15. It is more than 20 means you should suspect in a renal cause. That is the chloride wasting. If it is less than 15 or so, then you can take it's a chloride responsive with the GI losses and other things. Right. Okay. Right.
Good point.
Sir,
proceed.
yes, sir. So like he was evaluated at outside hospital. They have done genetics, which is showing homozygous autosomal recessive pathogenic variant of cystic fibrosis and deletion of 508. And at 8 months of age, pancreatic elastase in stool was done, which was 205 microgram per gram. So even though in cystic fibrosis, like pancreatic insufficiency is less than 200 microgram per gram, that is mild to moderate. In this kid, the kid also has clinical features which is suggesting of cystic fibrosis. So we took it as pancreatic insufficiencies.
Thank you.
We have planned CT chest in follow-up, sir.
No, I would be interested not just in CT. What about the PFTs? PFT is something that you can do because see, sometimes what happens is these V's as a part of airway disease may be missed throughout, maybe not presented by the mother. Sometimes they don't perceive the V's. You may not be able to escalate the V's if you have missed during flare-ups. I'd be rather interested to know a normal chest X-ray is there, but pulmonary function test is something which you can do, because ultimately what decides is what is the physiology than anatomy of the lungs. You understand my point? PFT is a very important test. Dr. Anthony would teach you more. Probably if you take one PFT of this child, he would teach you more about FE1 upon FEC, restrictive, obstructive diseases, so on and so forth. And remember, not this case, but many cases of cystic fibrosis may have PFTs similar to an obstructive lung disease, mimics of asthma, but for the wet cough and other variations. Okay, but that's an important thing that you just add. And it is doable at your institution, right? Yeah.
Yes, sir. So coming to the treatment, sir. So treatment is based on multidisciplinary approach, and first we have to change the dietary. We have to make some changes in like dietary modifications, high protein, high calorie, and high fat diet. So with vitamin supplementations and airway clearance therapy. So first with
Did
the
you give
pancreatic
enzyme replacement therapy, ERT?
Yes, sir. We have given, sir. He's taking
How
25.
expensive? Some
Sir,
20,000-30,000 they could spend.
yes, sir. It is around 10 to 20,000, sir. Yeah.
They could spend that much. Yeah. Good.
Yes, sir.
As a postgraduate, should remember for all chronic diseases, economics become the biggest challenge, and you should form parent support groups. One parent will support the other. Sometimes you may have to get one packet which will be shared by others. Not just that, even the availability, let's say hemophilia, thalassemia, and diseases like that form support groups of the patients, because the treatment is not just medicines for them. Lot of support is required for them. Form groups of the parents. That may be a small learning for you at the end of the day, and at the flagging of the case. I got a diagnosis by genetics, which is a confirmatory diagnosis. Good that you have the diagnosis. What is the prognosis from the genetics? Mother will ask you, spend 25,000 for genetics. Please tell me what is the genetic horoscope.
Yes, sir. With the good airway clearance therapy, the prognosis will be good, and if we offer evac after modifying agents, it will improve the prognosis.
I wanted to tell all the audience who are listening. Arti, kindly, Kritika, permit me 30 seconds more.
Sure,
because you told me 10 minutes only 30 seconds more.
Yes.
There is a difference between bronchiectasis in an adult and a bronchiectasis or a suppurative lung disease in a child. Whenever you give the news to an adult, it is like your lungs is burned out, your bronchi is already dilated, it's irreversible. But remember, the so-called irreversible defined bronchiectasis, a part of it is reversible in children. Even it is contrary to the statement. You understand my point? Bronchiectasis means irreversible ectasia. But in pediatric bronchiectasis is an exception because the airways continue to grow up to alveolar growth is up to 6 to 7 years after birth. There is a chance of recruitment and reversibility that is offered in bronchiectasis in children. Probably this could explain Dr. Anthony's observation that why we are not seeing clubbing in some of the areas. It is possibly because airways outgrow probably the suppuration or the irreversible damages, which I don't know. I'm just hypothesizing. But the point is, the pediatric bronchiectasis is not a bad news as much as an adult bronchiectasis is. This is the scope for pediatricians to give a ray of hope, because this is a hope that you need to give for this child. So you must demonstrate even reduction in the ectasia of the bronchus can be demonstrated on CT scan if you learn. I would share some of the articles on reversibility of bronchiectasis in pediatric and the scope of it. You can see in PubMed and a lot of literature. There's an outpouring of literature on ectasia in children. Is it reversible? On this caption, you do search and you will get a lot of articles on that. That's something which is a ray of hope for these parents who have spent so much. And that's the importance of managing them. Otherwise, if it is end of airway caliber, then why will we give protein supplement? Already damaged, isn't it? So there is a scope for reversibility, which is very, very important. And that is the ray of hope for these parents. We remember, keep them alive, keep them happy, and they will stick to you for life. Anthony, your experiences on handling so many cystic fibrosis they were handling.
Yeah, regarding the diagnosis for chronic cases, as you said, that's very important. It's not only tell about the biological diagnosis, you also tell about the psychosocial diagnosis, how they are able to cope financially with the problem. Therefore, this patient was earning like 30,000 rupees per month. They are spending about 10 to 15,000. Therefore, it's they are finding it difficult actually, especially during exacerbation. Each exacerbation might cost about 30 to 50,000 in a private hospital, treated with antibiotics and admission and everything. Therefore, it's important to know how they are coping and how their mentality. And some of the patients, the disease behaves different in different families. If the mother is motivated and educated, they do really well. The children do really well. And this is one of and the kids. Mother is MBA, she's educated and she is motivated. She is doing really well. The good thing about the genetic diagnosis, as you said, if you have a genetic diagnosis, if it is Delta 508 mutation, like this patient, for 50% of our patients have Delta 508 mutation. And now drug is available for free on a compassionate basis at CMC Vellore. And this patient has registered with CMC Vellore, and they'll be getting disease modifiers at 6 years of age. Therefore, the prognosis is going to be good for this particular patient. Therefore, and it's going to be lifelong treatment with cystic fibrosis disease modifiers. I think they can have almost a normal life. This child can have a normal life.
But Sneha Varki would be very good resource person at CMC Vellore. Most of you know.
Yeah.
Anthony, she must have also seen this child and
probably. Yeah. I think this patient went for registration a month back, and I think they will get the medicine next year.
Okay.
It's a very valuable information for all of us, sir. Thank you.
Is this disease registered under Ayushman Bharat in Tamil Nadu scheme? If not, I think most of you who are listening may be the influencers at the government level. And most of such diseases for which the prognosis is not that good, or it is difficult financially to manage. I have also written a lot of letters to the governments to include them. It is a futile exercise, but one fine day, somebody may listen to you. You should not stop knocking the doors, because if the financial support comes from the biggest financier, there's a government, then nothing like it, isn't it? It's difficult for them to manage at their own earning or corporate level. It has to be insurance based, and the best insurance available is Ayushman Bharat.
Oops.
Yeah, please go ahead.
Murugesh sir, your concluding remarks, please.
Hello?
Your
SPS,
concluding
sir.
remarks.
Yeah, very nice presentation, excellent discussion. And finally, for PG exam question, the reversible bronchiectasis is one thing which occurs, which is a term which was described earlier, where in conditions like post-measles state, post-pertussis state, post-pneumonia state, post-foreign body state, if you do a bronchogram, it will show bronchiectasis. And if the child recovers with good physiotherapy and postural drainage, the bronchiectasis will become reversible, and that is called reversible bronchiectasis. The earlier term in radiology books was pseudo bronchiectasis. Okay, this is an exam question often asked. And one more question asked in the exam, bronchiectasis sicca. That is, bronchiectasis in the upper lobe, like this child, may not have any expectoration at all. That's called bronchiectasis sicca. Right? These are the standard exam questions. And please go through Nelson. The chapter on bronchiectasis, Nelson, is extremely good. From the exam point of view, it's more than enough. And of course, go through the cystic fibrosis guidelines of from All India Institute of Medical Sciences. Thank you. Excellent presentation by Dr. Aarti. Well done. Don't get worried about, Dr. Subramania's comments. Okay, Subramania wants D+. Okay, you and me want A+. That's good enough.
Sir,
You would have given
Balasubramanian
D+.
sir,
I would have given you D+.
whatever may be her marks, Aarti, after your exams, you come to my hospital, I will observe you as one of the teachers any day.
Thank you.
What else you want? You are
What a
settled in
prize.
life.
What a gift to you, Aarti.
Any day you can walk in and you can remind this, take a snapshot and tell me, sir, we presented and we want a job. I will give you the job any day you want in our hospital.
Thank you, sir.
Thank you, sir. Very good presentation, Dr. Aarti. It is always a pleasure learning from all seniors, Subramania sir and SPS sir, always you learn something new from them.
Anthony sir, do you have anything to tell?
Thank you, sir.
So shall we conclude, sir, now?
Yes.
Yeah.
So,
I would tell you 1 second, beta. Only one line from me.
Yeah,
I would thank all of you from Tamil Nadu who are my co-brothers who have taken my name Subramania, and therefore you have felt that I'm part of most of you, and Balasubramanian sir for keeping half of my name inside him. So many times people have congratulated me after listening to Balasubramanian sir lecture also. I have shared these jokes in a couple of conferences. Sir talked very well and somebody in the coffee hall complimented me. Sir, I heard that Subramanian's lecture was very good. Thank you very much. Then I said thank you and passed it on to Bala sir. So this is happening, and many times it is not other way around. Don't worry. And it was a great learning from teachers like Balasubramanian sir. Anthony, you are also one of my teacher. I still remember that comment on adrenaline you have given. And all the youngsters and little pretty girl Aarti, you have done extremely well. I was not trying to reduce you on exams, but this was pre-exam and therefore you would get a couple of marks more from these tips. I would be very happy. Murugesh sir, first time I'm interacting with you on as a co-panelist, and it was so nice. Kritika, kindly accept my apologies for targeting the questions to you because you were next to me on the screen, and therefore it was just a wrong missile fired from the Middle East. So with these words, so it was wrongly fired on allies rather than on the enemies. So therefore, with these couple of words, I would thank all of you. I would request Dr. Balasubramanian sir, keep calling me again and again, even if not as a panelist. Sometime here and there, we learn a lot from you. Dr. Aarti, back to you, and Dr. Kritika, over to you.
Okay.
Thank you so much, sir.
Thank
It was
you.
such
Thank you, sir.
friendly, lively, and endearing assessment of students, sir. You are an angelic examiner. Any student would love to have as an external, sir. Thank you so much for accepting our invite and offering your words of wisdom. SBS, sir, as cricket fans, we not only adore Sachin Tendulkar, we are ardent fans of MS Dhoni and SKY too, like you, sir. Murugesh sir, thank you so much for your valuable contributions. Anthony sir, your students were amazing, and it's a proud moment as a mentor to you. And Aarti, it was an excellent and a very comprehensive presentation. All the best to you. And I don't know that other girl name. May I ask you? You're mute. Huh? Hi.
Deepika.
Deepika.
Deepika,
You
I'm
are also
asking test
welcome to our
wishes.
hospital.
Thank you.
Okay.
Thank you.
Thank you, sir.
Shall we
Yes,
conclude, sir?
Subramania, sir.
SB,
Yes.
sir.
Yeah, yeah.
SB, sir,
Bye-bye.
shall we conclude?
Yes,
Sir,
Pastor.
Yeah,
Good
yeah.
night. Good night.
Thank you so
Thank
much
you,
and good
sir.
night, everyone.